Well, hi, everybody. My name is Garrett Schmidt, and I'm the managing editor for VBC Exhibit Hall. Thank you all so much for joining us for today's live webinar hosted by Topcon Screen. And very excited about today's topic. It's called Preventative Care plus Equitable Care equals Accountable Care. And I got a chance to hear a little bit of this presentation earlier, and I was very impressed. So I think you guys will really enjoy it. So a couple of items of note before we get started, just some housekeeping stuff. Everyone is joined today in listen-only mode. It's the traditional webinar format, like what we usually do. So you don't need to worry about muting your microphone or turning off your camera or anything like that. We can't see you or hear you. However, we do want to hear from you. So we're going to have a time for some Q&A towards the end, and at which point you can ask questions to our speaker. And at any point during the presentation, what you can do is actually submit your question using your control module. There's actually a little area for questions. So if you put your question there, we're going to get to as many as we can during the allotted time. If for some reason we aren't able to get to yours, we run out of time or whatever, someone will reach out to you via email later. So don't worry. So even if we're wrapping up at the last minute, go ahead and ask your question and we'll get to it. And then finally, we are recording the session. So what's going to happen is when we're done here, you will receive an email about maybe an hour after we conclude. And there will be a link to the recording, also to where you can download the slides. So you can review it or share it with colleagues, and we hope that you do. This is something that we want you to definitely get a lot out of. So without further ado, I would like to introduce our speaker today. We have Mr. John Bartolevich, and he is Healthcare Economics and Reimbursement Manager with Topcon Screen. So welcome, John.
Thank you, Garrett. Thanks, everybody. Thank you for spending a part of your day with us, and good morning or afternoon, depending on where you're at. I am going to drop off camera while I am doing the presentation. I myself suffer from ADD, so if I see things going on in the background, I get distracted. So I don't want to distract anybody with any movements, coughs, anything like that. So I am going to drop off camera right now. I have been in the diabetic exam space for roughly 13 years, and it is a labor of love for me. I've been in healthcare sales 30 years, but as I said, the diabetic eye space for the last 13. Topcon has over 80 years of working with eye care professionals as we provide the equipment and diagnostic equipment, software solutions that many of you have probably seen in your optometrist or ophthalmologist office recently, if you visited them recently. Over the past several years, we decided to get into the diabetic eye exam space and point of care testing with primary care. And that's what we're here to talk about today. Preventive care plus equitable care equals accountable care. And as Garrett had said, if you have any questions, please feel free to drop them into the chat area. So our learning objectives today are to discuss an overview of the ACO programs that have been put forth by the CMS Innovation Center, to talk about health equity and social determinants of health and their effects on what you do as practitioners and providers. The positive impact that point of care testing has on health equity and social determinants of health, and how the point of care diabetic eye exam helps you achieve that measure. So I took this slide and this information directly from the CMS Innovation Center, and these are 4 of the ACO programs that are currently available for ACOs to join. Medicare shared savings and the REACH models are probably the most popular accountable care organization models in the US. The MSSP model is a voluntary program, you're all aware, and it encourages providers to form ACOs and take responsibility for the outcomes of their patients. The REACH model introduced earlier this year, well, I shouldn't say introduced earlier this year, it's been around, but is really focused. We started focusing a lot more on it this year. is a risk-based ACO model that provides more advanced alternative payment arrangements, which really now we're talking about getting into capitation, preferred provider arrangements, and really focusing more on upside and downside risk. And then the most recent addition is the AHEAD model, which CMS is going to collaborate with specific states to curb healthcare costs, improve population health, and advance equity by reducing the disparities in healthcare. What are the common denominators here? There's three. CMS wants to strengthen primary care. They want to improve care coordination, and they want to address and document the social determinants of health. So moving forward, just a couple of quick definitions. High risk, high cost, high need patients are defined as people of all ages living with clinically complex needs and functional limitations. They incur high healthcare cost in the present and likely to do it in the future. So the three definitions are: high risk represents potential future spending, high cost representing past or current spending, and high need, patients that are in need of more intense and more coordinated care. So who are these patients? They're your chronic conditions, complex medical needs, behavioral. They suffer from social determinants of health. But what's great is that ACOs, accountable care organizations, are well positioned to serve this population more effectively, and you have the financial incentives to do so. ACO payment models incorporate annual global budget targets for defined populations, and you have a strong interest in improving the care for this population. And a lot of it is required by the regulations for you to provide person-centered care. So, going to ask a polling question here.
All right. So, John, I pulled this up on the screen here for everybody. So this is anonymous, but if you would go ahead and answer, then what we can do, and this is select all that apply, and then we will share the results. So we've got several responses coming in here. So we'll give it a few more seconds here. So and again, the question is, are you using any of the programs below to target your high need, high cost individuals? And again, all that apply here: traditional care management, nurse care coordinators, embedded in physician practices, PCMH, nurse care coordinators centrally located, post-acute skilled nursing facilities, SNFs. And it looks like we've still got some results coming in, so I'll just give it another few seconds here. And then I'll share this, and you can kind of see where you stack among your colleagues. And again, this is anonymous, so. All right, looks like most of the results have come in here, so I'm going to give it about 10 more seconds, and then I'm going to go ahead and shut it down. Okay, about 5, 4, 3, 2, and 1, and I'm going to go ahead and close it out now, and then I will share the results. Okay, John, are you able to see the results on the screen?
I can.
Okay.
And here's what's interesting. In 2017, the Institute for Accountable Care conducted a research study, and they specifically asked ACOs and their members, what are you doing to address your high cost, high need patients? 80% said they were using some sort of traditional care management, 73% nurse care coordinators embedded in physician practices, 58% PCMH, 57% nurse care coordinators centrally located, and 50% post-acute and skilled nursing facilities. So Fairly similar results here. So let's talk about health equity and health equality. And I love this slide. I've seen various versions of this slide, but to me, this in a nutshell explains what we're talking about here. And I got this from the Robert Wood Johnson Foundation. And as you can see, there is a tremendous difference between health equality and health equity. Because looking at the slides, if healthcare were a bike, everybody on the left got equal healthcare. They can't use it, but they all got it. Whereas when we look at the folks on the right, everyone got what they needed, regardless of what their barriers, their circumstances, and their conditions are. And that's what we're charged to do with our healthcare system. And ACOs, again, as I said earlier, are on the forefront at being able to drive this and drive this change. So health equity takes into account the different cultures, access to resources, socioeconomic status of our patients. And many patients experience a health disparity. According to Healthy Cities, your zip code influences your health more than your genetic code does. We often relate chronic diseases to habits such as diet, lack of physical exercise, smoking, or hereditary. However, the biggest factor that influences health is the environment in which we live and the circumstances in which we live, such as poverty, lack of decent housing, overcrowding, environmental safety, remoteness from basic services. They can all have tremendous impact on a patient's health. So much so that an individual's life expectancy can vary by as many as 25 years between neighborhoods in some US cities. And in those same cities, it's similar outcomes in gaps with infant mortality, obesity, violence, and chronic conditions. Black men are more likely to die from prostate cancer than white men. Rural communities have higher incidence of preventable conditions such as diabetes, some cancer, and obesity as compared to their urban counterparts. Racial and ethnic minorities have a greater proportion of chronic disease and premature death as compared to white folks. So the key takeaway here is that health and healthcare is foundational to a healthy and economically vibrant society. So we all know what the social determinants of health are, and all of you participating in ACOs are now charged with documenting this care and these risk factors. It's important to note that 68% of Americans have at least one social determinant challenge, and 52% have a moderate to high SDOH risk in at least one category, and that's according to the American Journal of Managed Care. As an example, people that don't have access to grocery stores with healthy foods are less likely to have good nutrition, and that raises their risk for conditions like heart disease, diabetes, and obesity, and lowers their life expectancy as compared to people who do have access to good grocery stores and good healthy foods. Another example is people who live in unsafe neighborhoods and can't get out and get the physical activity they need to stay healthy. So it's clinically important that we create programs to help patients affected by social determinants of health. As you can see on the slide, we have the populations that are affected the most and what a lot of these disparities are. Medical care, according to New England Journal of Medicine, in a study written by Schroeder et al., said medical care accounts for only an estimated 10 to 20% of outcomes. Think about that. 10 to 20% is based on your medical care. African Americans, Hispanic or Latinos, Native Americans, Pacific Islanders, Asian Americans are more likely to develop prediabetes and type 2 diabetes. In the United States, adults have a 40% chance of developing type 2 diabetes. But if you're a Hispanic or Latino adult, your chances are 50%, and you're much more likely to develop it at a younger age. Diabetes complications hit you harder as well. Hispanic and Latino people have higher rates of kidney failure caused by diabetes, as well as diabetes-related vision loss and blindness. Adults who experience food and nutrition insecurity are 2 to 3 more times more likely to have diabetes than people who don't experience food insecurity. This leads to them having higher A1Cs, greater diabetes-related complications, hospitalizations, and poor mental health. And I want to stress here hospitalizations, because that is one of the things that, you know, in some of the ACO models, you are charged with trying to keep down hospitalizations down and readmissions down. So going back, lower nutritional foods can cost less and provide lots of calories, but they also cause hyperglycemia and increase the risk of diabetes-related nerve damage and vision loss. And unfortunately, healthcare costs twice as much for people with diabetes as those without diabetes. And there are many patients out there who have to make a decision every day. Do I put food on the table or do I treat my diabetes? This is a heat map from 2007 showing the percent of adults with diagnosed diabetes. The brighter the red, the greater the number. This is subsequently exploded, and there's greater concentration of the diagnosis of diabetes. But one interesting finding that still is prevalent and hasn't changed over the years is the diabetes belt. And this is a care area of 644 counties, predominantly in the South, that have the highest incidence of diabetes in the country. So if you're in one of these states or counties, we've got a pandemic on our hands, or epidemic, I should say. So as you know, I've been focusing on diabetes. 37 million Americans have diabetes. That's 11.3% of our population. The interesting thing is 8.5 million people have it, but don't know it. And that's according to the CDC. Most diabetics also suffer from chronic conditions like hypertension or obesity. And these patients are at higher risk for complications of the kidneys, as we talked earlier, heart, eyes, lower limb amputations. They need to be tested and screened on a regular basis. Diabetes is one of the very few diseases out there that attacks both the large and the small blood vessels in the body. And it's because of this that the American Diabetes Association recommends annual testing for kidney tests, cardiac events, A1Cs, lower limb amputations, and vision loss. One thing that we do know is point of care testing at the primary care level has been very effective at closing care gaps. And we know this basically just on some of the tests that the diabetic patient has to have. Currently, diabetic patients receive in point of care, they get their A1C checked, they get their kidney function test, they get a cholesterol test, and they get their foot exam. I'm old enough to remember, and if you talk to any physician that's been practicing for a long time, they can remember when they used to send out their A1Cs, and they experienced some of the same care gap issues that they experience now with the diabetic eye exam because it was a referral. Point of care testing improves patient engagement, it gets results back quicker, and it is reimbursable and is available for closing care gaps. So we're going to ask poll question number 2.
Okay. All right, I am launching this one, and this one is for you. I have seen an eye care professional And please select one. Again, this is anonymous. Within the last year, within the last 6 months, within the last 4 weeks, or I can't even remember the last time. So we got the results kind of coming in. Don't be embarrassed. Again, this is this is anonymous, but we'll paint probably a good picture of where most people are right now. Of course, those of us who wear contacts or glasses don't have the luxury of not going at least once a year. Okay, we still got some results coming in here. I'm going to go ahead and close it down in about 5, 4, 3, 2, and 1. And I'm going to show the results. All right, John, are you able to see that?
Yes, I am. And you all are ahead of the curve because statistics show that up to 50% of diabetics do not get this sight-saving exam done annually. We look at improving access to care, and in 2018, 95% of patients hit the guideline for kidney function testing, but only 72% did for the diabetic eye exam. And when we looked at ACO 41, only 52% did. So it's not, 20% more patients got screened for one complication over another. It's not that we value kidneys more important than eyes or think they're more important than eyes. The reason is kidney function testing is done as a combination of a specialty visit and point of care testing, whereas diabetic eye exam is predominantly done as a referral. And for a lot of different reasons, primarily social determinants of health, which we're about to get into, patients don't want to go to a second, what they feel is unnecessary appointment. So you see on the screen, you have the normal picture, you have the diabetic retinopathy picture. Diabetic retinopathy is the leading cause of blindness among working adults in the United States. 40% of diabetics will have some type of pathology, not just diabetic retinopathy, but it could be glaucoma suspect, cotton wool spots, some level of eye pathology is present. And at least 10% of those patients are at immediate risk for blindness or vision loss. There's no symptoms in the early disease you see normally. But once a patient becomes symptomatic, moving from mild to proliferative, they experience flashes of light, floaters, and spots. And as with most conditions, early detection leads to better patient results. And in fact, 95% of vision loss caused by diabetes can be prevented. And the scary thing is, despite everything we know about diabetes and diabetic retinopathy, we're still at a point where up to 50% of diabetics do not get tested for this exam. So what are the reasons? We could blame it on the current process, but the current process works some of the time. Patient comes in, you refer, they have their visit, their wellness visit, their issue that they came in for the day. You ask them if they had their eye exam done. They say no. You refer them out. They go see the eye care professional. You get a report back. That closes your HEDIS measure. Unfortunately, most of the time, though, patients go, but your staff has to waste an unreasonable amount of time chasing down the chart, trying to get that report. But then patients don't go, and the reasons for this are many. We like to say it's compliance, but it could be scheduling, could be transportation. They may not have access to a vehicle. They may have to take care of a family member. They may have children that are sick. They may have financial concerns. But the issue is this creates a care gap for you and the patient, and it has an impact on their outcomes, on reimbursements, on your quality measures, and on risk adjustment. So I like to always point out that not every patient in the physician panel will be part of an ACO or ACO REACH or a HEAD. 2018 ACO 41 measure was diabetic eye exam. 52% of patients achieved that measure. Same year with CMS, it was 72%. ACOs have subsequently removed the measure, but it wasn't because it wasn't an effective measure. They removed it because of administrative burden. But these patients still affect your utilization rates, your hospital admission rates. So we need to do everything we can to help keep them in a position where they're not taxing the healthcare system. Many plans consider this to be the hardest quality measure to close, and your gap is going to vary based upon your population and your payment model. The one thing I want to point out is that the gap is those patients who aren't going and getting this exam done. The patients you have no record or documentation that they've received this exam. Some of the impacts on the care gap, the cost of care to the patient and the system. It can cost as much as $10,000 annually to treat diabetic retinopathy. Typically, it's between $600 and $1,000. As we said earlier, there are no symptoms for mild retinopathy. Many patients have no idea that they have any type of pathology until they get this exam done. And the important thing to note is that when treatment is required, it usually is going to be some combination of injections into the eye and lasers. So point of care testing works. It's been around for a while. It's been at the Indian Health and Joslin Vision Network. They've been doing this since 2000, and their program has significantly contributed to a decrease in diabetes among the American Indian population. The Veterans Administration as well has been an early proponent of diabetic eye exam, and they saw it as an opportunity to engage their patients, but patients have reacted positively to the ability to have this test done without the need to have drops in their eyes. So how would screening work with Topcon? I'm happy to say I'm going to talk to you about two different models. The first model we're going to talk about is our model where we use human readers, eye care professionals. Patient comes into your office. The most successful programs treat this as if it was a vital sign. So they get their blood pressure, they get their A1Cs, they get their pulse ox, and then they get a picture of their eyes. That is sent up via a HIPAA compliant encrypted data transmission software called Harmony, where it is then available for an eye care professional to look at the exam, look at the images. They'll go ahead, they'll write a written report, and they will send that back to you within 48 hours. Typically, the turnaround is much faster. It's usually within 24 hours, but we contractually guarantee 48 hours. The important thing to know here is not only will these doctors find diabetic retinopathy, if there are any other pathologies, increased cup to disc ratio, glaucoma suspect, cataracts, anything of that nature, they will also notate that on the report so you can let the patient know. Also, if they find anything emergent that requires immediate treatment, they will let you know that as well. So that's option one, Topcon screening workflow with eye care professionals. Effective this month, Topcon is now proud to announce that we also have a fully autonomous option for your office. And by that, we can place a Topcon camera with AI Health's diagnostic screening AI algorithm and allow you to get immediate findings as to whether or not your patient has diabetic retinopathy or not. Comes back as a refer, no refer diagnosis. It is fully reimbursable via fee for service. It also meets the HEDIS measures, quality measure 117 And value-based incentives for both options can be up as much as $1,700 per patient. Topcon is camera agnostic. We do have two different cameras. We have a handheld camera, generally best for mobile opportunities or very small practices. Generally takes about 4 minutes to capture an image, 4 to 5 minutes to capture an image. And it does require that the patient get some natural dilation in a darkened room. We also have the robotic, fully automatic camera that captures both eyes in less than 2 minutes. No need for dilation, no need for natural dilation. And we work with you and your staff to determine which model is the best model for you. So as stated earlier, not every patient in the panel will be part of the ACO. There's a lot of different things out there to take into account. And as we work together to provide quality care, we find that for the patient, this gives them peace of mind, and it gives them early detection and saves them money if they do have disease. It's fast and easy to use for the provider, minimal impact for the provider, minimal impact on the workflow, and it helps them improve control of gives them improved control of diabetic care for their patients. Eye care providers like this because it gets them targeted referrals. So instead of patients who may or may not have disease being at the ophthalmologist or optometrist, they're only getting those patients that actually need to be there for a disease state. Systems and ACOs benefit from this because it gives you improved quality scores and measures. It's point of care testing. It gives you improved payments. And lastly, payers like this because it's a built-in metric for them. They can track it, and it lowers the rates of advanced disease and improves the cost of care. I always like to point out that in 2019, the average star rating for this measure was 3.7. Bonuses don't apply until you hit 4 stars or higher. So we've got room to improve on that. A couple of case studies. UC Davis out in California launched a pilot study in 2018. They used only the lowest paying fee-for-service CPT code, 92227. They showed that the program was budget positive when they factored in all of their opportunities for revenue, and they eliminated 178 clinic visits to specialists that would have been unnecessary because they would have only been there to screen, not to treat. They increased their screening rates from 49% to 63%. Valley Medical Group out in New Jersey, they were looking to standardize care for their diabetics, and they elected to join the AMGA together to goal innovator track eye care cohort. And their goal was to screen those true gap patients, those patients that we had no record of them having the diabetic eye exam. They did it in a two-pronged approach. In their ophthalmology clinics, they scheduled every Wednesday a diabetes day, and they screen patients every 15 minutes during that time period. They also deployed in their endocrinology practices over a 4-month period 2 NW400 cameras. That was the robotic camera that I showed you earlier. What they found was that 21% of their patients had some level of diabetic retinopathy, 30% had pathology, and 60 eyeballs were saved. They increased their screening from 40.7% to almost 50% and screened an additional 775 patients that year. And at the conclusion of the collaboration, they kept those 2 cameras and they added several more, and they continue to add more. Last case I like to talk about is Crozier Keystone, one of the largest health systems in Eastern Pennsylvania in the Philadelphia area. They partnered with their an ophthalmology group in their area in Topcon. They placed 2 cameras in 2 facilities as a pilot to see if it was going to move their numbers. First 80 patients, they found 30 abnormal studies. So these were patients that were not under the care of an ophthalmologist, again, because they focused on that care gap. The medical director of primary care said that this program is an effective frontline defense against diabetic retinopathy for Crozier. So how does it work? Despite this being the hardest measure to meet and implement, it can be done, and it can really be done effectively and help you to control the cost to get this done. One of the biggest reasons it hasn't been done in the past is cost of capital, questions around reimbursement, concern about workflow. Well, Topcon has been proven to help offices eliminate those concerns. You have 2 components to the program. You have a camera and you have the diagnostic report. As I said earlier, we're camera agnostic. You can purchase a camera from us. You can lease a camera from us. We offer exam bundles. We offer the autonomous AI. If you already own a camera, odds are we will be able to hook it up to our platform and you can use us as your reading center. The other portion is the diagnostic report. It is a per patient exam fee. Every time you send a set of images up to the cloud, you will be billed $25. There are no other software fees. There are no other training fees. So it's that simple. You have a camera and a diagnostic report. 4 easy steps to get this exam done. We also work with you in onboarding to offer workflow optimization and reimbursement support in conversations. And with that, Garrett, I think we're open for questions and discussion.
We are indeed. And if you have a question that you would like to ask to John, go ahead and submit it now using your control module. There's actually a space for questions that's different than the chat. So go ahead and drop it in there, and we're going to get to as many as we can. First question here is, how difficult is it to get a retinopathy screening program up and running?
As you saw in the last couple of slides, it's really very easy. We put you in contact with an area sales manager, the national sales director, or myself. We discuss what your practice population looks like, how many diabetics, what your actual care gap is, and then we just work with you to decide what's the best program to put into place. And typically, we can have an office up and running within 3 to 4 weeks of contract signature.
Great. Next question here is, how do I know which program will best meet my needs?
And again, this is going to come down to what your diabetic population looks like. We offer bundled packages where you can get pay for just the exams. You purchase a certain number of exams to handle your diabetic population. We can do a leasing program where we lease you a camera and then you just pay per exam. We can do the autonomous read. And a lot of that decision making is easily done once we start having the conversations about the practice and what you're trying to accomplish and the number of diabetics that need to get this done.
All right. Next question here is, ACOs don't target this measure. Besides good patient care, why deal with the administrative burden of it all?
Good patient care is the most important reason to do this. And I'm also going to add, this isn't the first time I've heard this question. You're absolutely right. ACOs are not responsible for this measure anymore. However, ACOs are responsible for maintaining high quality care. Many of you are in patient-centered medical homes, so you are required to hit HEDIS measures. This does help to lower utilization when you think about it. Diabetic $25 eye exam in the screening versus $10,000 or $1,000 to treat diabetic retinopathy. So you're going to impact your utilization. And then if, patients go blind or they start having sight issues, they start having falls, they end up in the hospital. Now you're looking at your admissions and your readmission rates. That's first and foremost. Secondly, not every patient in your panel is going to be part of the ACO. You're going to, at least in most ACOs, most practices, you're going to have patients that are commercial. They may be Medicare Advantage patients. They may be Medicaid patients. And this exam is covered by all of those typically, and quality measures do come to play with every one of those payer models.
Okay. Next question is, should we anticipate any pushback from payers on this?
To my knowledge, there's only one payer out there that does give pushback, and that is only on the fee-for-service component. They do highly reward the quality measure, quality incentive for closing this care gap. But the majority of plans out there, be it CMS, Medicare Advantage, commercial payers, even state Medicaids, do reimburse for this on the fee-for-service. But the bigger picture and the bigger implication to look at is, how does this affect my quality measures and my quality bonuses and my star ratings?
Okay, next question here is, how can you reach out to people who are high risk for diabetes but are not responsive to care coordinator reach out?
That's the $64 million question. Yeah, I go to a lot of, I attend a lot of trade shows. I go to a lot of HEDIS and quality measure, and there's a tremendous amount of, there are tremendous resources now being spent on driving that population, getting them in for that care. I wish I had the golden answer. I don't. It's just a matter of phone calls, mailers, catching them when they do come in for that visit. As a diabetic, I don't always go to my specialists. I always go to see my primary care doctor and my endocrinologist. So if we can catch them there while they're there, that helps.
Yeah, great question. Next question here is, can you speak to any AI applications on the diabetic population, and or is this incorporated in the screening process for Topcon?
When you, the one component I mentioned, we are partnered now with a company by the name of AI Health. They are one of 3 companies that has an AI algorithm in the US. I'll also add that every one of the companies that does have an AI algorithm can work on the Topcon NW400. We tend to be the camera of choice for the AI vendors. But yes, we do have that option. And again, it's just take the images, and within a minute, 2 minutes, you get a refer, no refer response back. If it's a refer, obviously you extend referral. If it's not, you just know that you have to catch this patient again a year from now.
Great. And then finally, is a physician required to operate the machinery, or can that be done by a mid-level?
This can be, the cameras are so easy to operate. They can be done, we've got small offices where the receptionist actually takes the images.
Oh, wow.
So all you really need, the physician does need to write the order that the exam take place. And then anybody on staff can be trained to utilize the camera and take the images.
Very cool. All right. Well, that is all the questions that we have for today. John, thank you so much for this presentation. This is great. We do a lot of these. I really enjoyed this one particularly. I thought it was very well presented. And a lot of great information here. As we close out, I wanted to encourage you all to head over to vbcexhibithall.com and check out the virtual booth for Topcon Healthcare, which is there. And you can learn a little bit more about what they're doing and some tools that they have, and watch some videos and just some cool stuff there. So definitely encourage you to head over there and check it out, as well as some of the other resources at vbcexhibithall.com, which is also, by the way, where the recording today is going to be archived. So we have a library there that you can view all of our webinars, and this one will be there as well. But if you'd like to reach out to John directly or to the Topcon team, feel free to do so. His information is here. And you can, again, ask him any questions that you had, request RFP, any of that kind of stuff, or feel free to reach out to me as well directly, and I'm happy to facilitate an introduction for you. We've been working with these guys for a long time, and they're a great team. I think you'll really be in good hands here. So, but thank you again so much for joining us today. I know there's a lot vying for your attention right now this time of year, so appreciate you spending your afternoon with us. Hope you have a wonderful rest of your day. See you in the next one.
Yep. Thank you very much, everybody.
Bye-bye.